All right, thank you very much. I'd like to thank the organizers for inviting me, and I'd like to thank everyone for being here until this time. And we'll start and kick on with. Okay, so these are my disclosures, nothing that is affecting my talk today. And the outline, very quickly, I will touch on the background of hereditary angioedema with Dr. Shoaib has beautifully made it easy for me now to jump on the treatments and the advances in biologics. So hereditary angioedema, as it was mentioned before, an autosomal dominant condition, which causes really painful swellings of the interdermal and submucosal layers due to C1 inhibitor deficiency as well as mutations. And for the sake of the treatments, I'll concentrate more on the HAE type 1 and type 2. This is the pathway that's been elaborated previously, where all the biologics and treatments are targeted towards these pathways as well as the end products, the contact system complement and the fibrinolytic system. So the HAE guidelines, we have so many of these guidelines, all aim to provide patients with on-demand treatment once they're diagnosed, and for short-term prophylaxis for patients who are prone to develop HAE attacks due to simple procedures or even infection or dental surgeries. Long-term prophylaxis are for those patients who have uncontrolled disease. And for this reason, it's so interesting that such a rare condition, such as hereditary angioedema, an orphan disease, has so many trials and studies and so many medications available or are currently being evolved. And if we look back to the timeline for hereditary angioedema treatments due to C1 inhibitor deficiency, it was started with testosterones and fresh frozen plasma, antifibrinolytics, and went over for C1 esterase inhibitor, then kallikrein inhibitors, bradykinin antagonist, recombinant C1 inhibitor. Then we came to the subcut prophylaxis, monoclonal antibody prophylaxis, and further on to the small molecules, as well as gene therapy. So I'll try to cover as many as possible about the advances in the HAE treatment. We have the factor 12 monoclonal antibodies, plasma kallikrein monoclonal antibodies such as lanadelumab, inhibitors of plasma kallikreins, whether it is treatment or on-demand, parenteral or oral treatments, bradykinin antagonists as well. So the biologics for on-demand treatment, icatibant, as we all know, it's a synthetic peptide, which is very highly specific antagonist for the BK-B2R beta-2 receptor, and shows to inhibit the bradykinin vasodilation. In a phase 3 trial, icatibant was shown to be very effective for moderate to severe attacks at any location, with the reduced median time for 50% reduction in symptom severity. There was this also proved efficacious in laryngeal attacks as well, and a phase 3 trial for children and adolescents also showed safety and efficacy, and it's approved for children from 2 years onwards. Ecallantide is a specific inhibitor for plasma kallikrein, and it is a recombinant 60 amino acid long protein synthesized. So many trials have proven efficacy with 30 milligrams subcutaneous injection, which is superior to placebo, and maintained or sustained relief up to 24 hours when administered within 8 hours of onset of an attack. It is registered for children, for patients from 12 years and onwards, and unfortunately, because of the hypersensitivity reactions associated with it, more with the IV formulation, it needs to be administered in a healthcare setting. Experience to treat anaphylaxis. Going on to small molecules, we have the Calvistas, sabetrelstat, KVD 900. It's a novel investigational oral plasma kallikrein inhibitor for on-demand treatments of HAE attacks. So we're moving on from subcutaneous treatments or IV treatments to oral. It inhibits the high molecular weight kininogen cleavage in normal as well as HAE plasma. The phase 1 showed a rapid absorption with a half-life of approximately 2 to 3 hours in a dose-dependent fashion, and the protective dose at the 600 milligram was attained within 20 minutes and lasted for 8 to 10 hours. So in this phase 2 trial, briefly, in 50% of the attacks that were treated with KVD900, there was a 50% reduction in the visual analog score within 6 hours compared to 12 hours for placebo. And by 24 hours, around 74% of the treated attacks showed a 50% reduction in the score compared with placebo. As for the adverse events, they were mild or moderate in intensity, but not serious or severe that warrants the withdrawal of treatment. And the post hoc analysis for this, they looked into the location of attacks, and they found again 80% achieving symptom relief within 12 hours, regardless of the location attack, probably a little bit faster with abdominal attacks than the peripheral, but all really achieved excellent symptomatic control. Now moving to prophylaxis, lanadelumab, that I'm sure everyone here knows, is a fully human monoclonal antibody that binds plasma kallikrein, prevents the bradykinin production. It's indicated for the routine use of HAE from adolescents 12 years and older, but recently in February 2023, last year, it was approved to prevent attacks for children from 2 years and older. The recommended dose is around 150 milligrams every 4 weeks for the children from 2 years up to 6 years, and every 2 weeks from 6 to 12 years. And the dose is, as we know, 300 milligrams every 2 weeks for those older than 12 years. And it's not intended for treatment, so it's only for prophylaxis. And this is the phase 3 HELP study. I'm not going to elaborate so much on it, but this shows that the lanadelumab significantly reduced the mean HAE attack compared with placebo by 87% for those for the number of reduction in the number of attacks, and 83% of the moderate to severe attacks reduction. Patients who were attack-free, 44% during the period between 0 and 182 days, so within the 6 months. And when the drug reached the plasma steady state, which is day 70 to 182, the 77% of the patients were attack-free. No worries about the safety results. The main thing was injection site reactions. The open label was 132 weeks onwards, and again it showed a reduction of the mean HAE attack by 87.4%, and the attack-free 85% had almost a year with no attacks. Now, the oral plasma kallikrein inhibitor, which is licensed for prophylaxis, berotralstat. Several trials showed its efficacy in the APEX-1 trial and APEX-2 trials, that demonstrated significant reduction in attack at 150 and 110. The 150 milligram dose actually had a better result, with 50% of patients achieving at least 75% reduction in the attacks, and 23% had at least 90% reduction. The APEX-S was assessing the safety, the long-term safety at 48 weeks, and that proved to be tolerable and effective. And recently, the results for the safety of the 150 milligram through to month 24, again, they were tolerable and safe. Just worth noticing the abdominal GI effect was one of the common side effects that were mild and transient, and it was more with the higher dose 150 group than the lower. Effectiveness, they also had a clinically meaningful and sustained reduction in the attacks, with a median attack of 0 within 20 to 24 months. Worth noting that just last month, the berotralstat is now involved in a trial in phase 3 in children from 2 years. So the study is expected to end in February 2027. So we'll be interested to know the results of this phase 3. So subcutaneous garadacimab, this is a novel factor 12 monoclonal antibody currently in phase 3 clinical trials. And so it's an immunoglobulin, and it's actually a fully human immunoglobulin G4 monoclonal antibody, and it inhibits the factor 12 at the origin of the contact cascade system, and so it inhibits the production of bradykinin. Worth mentioning, it inhibits the thrombosis without impacting hemostasis. And in the phase 2 trial, which was a randomized double-blind placebo-controlled trial, it looked at those patients who were treated with either placebo or the subcutaneous monoclonal antibody over a 12-week period, and they found the dose of 200 milligram reduced the attack by 100%, and those with the 600 by 93%. No serious adverse events, and the safety data over 6 months showed, again, it demonstrated early onset sustained control of HAE attacks. There was a 100% reduction in the HAE attack rate per month, and a 71.8% attack-free in the first 3 months, and less so in the 6 months, but a significant attack-free rate of 61.5%. No concerns about adverse events, and long-term efficacy and safety are currently under study. Now, the bradykinin beta-2 receptor inhibition with PHV7416 or Parvaris. This is a new molecule which tends to inhibit the bradykinin B2 receptor. It has been studied for on-demand HAE treatment as well as prophylaxis, and there is an extended release tablet for the sake of prophylaxis. So in the phase 1 trial, they found that it has a very good, very fast absorption with a half-life of approximately 3.4 to 5.6 hours, which is approximately 3 times longer than that of icatibant. And in both the fasting and fed status, it managed to maintain a clinically significant therapeutic concentration in blood. So when it was dosed as BD, they found that the steady state remained for 72 hours, which makes it a good candidate for prophylaxis as well. The result from the study, the RAPID-1 phase 2 trial, where they did a double-blind, placebo-controlled, randomized crossover dose ranging trial. And so in this trial, they gave the patients 3 doses of 10, 20, and 30 milligrams, studied the pharmacokinetics and safety. And after that, they've given the patients the option to take this medication home, and they treat 2 attacks out of 3 with the medication and 1 attack with placebo. The primary objective was to evaluate the angioedema symptom relief within 4 weeks in acute attacks in patients with HAE. So what was the result? The result was a rapid absorption, which reached the peak within 30 minutes. The mean plasma levels were maintained 8 hours for the 10 milligram or 20 milligram dose, and more than 10 hours for the 30 milligram dose. What about the improvement in the VAS-3 score? So there was really a significant improvement in the visual analog score for the patient and symptom relief for all doses. I couldn't, though, understand the 30 milligram, as you can see here. So it's like more 10 to 20 milligram. There was a much more significant reduction, improvement in the visual analog score. However, all secondary key points were met, and less patients had to use rescue therapy. In the all the doses were tolerated with no significant adverse events. So now the studies will go on for the prophylactic treatment, and it's in phase 3 development. Now, the semi-final, or just before the last, is the STAR 215, and I consider it as a STAR. It's quite long-acting, so let's hope this actually manages to come through. It's a monoclonal antibody inhibitor of plasma kallikrein in the development for prevention, so not for treatment. And it has a very durable and long effect, up to 3 months. So probably patients can be able to have this prophylactic medication every 3 months. So the phase 1 trial was really promising, where they looked into the durability, the safety, and the durable suppression of the high molecular weight kininogen level, which was consistent with a robust plasma kallikrein inhibition to prevent HAE attacks for 3 months or longer in healthy patients who do not have HAE. And then they looked into the reduction in attacks in patients with HAE, as we'll see later. So the results from this phase 1 trial, it was safe and tolerable. Only injection site reactions that happened in all the 6 patients who were on the treatment dose. The immunogenicity, there were no treatment adverse drug antibodies that were detected. Rapid absorption with a half-life between 6 to 13, and it was estimated up to 117. But by day 84, when they analyzed this is a preliminary analysis, they found that the mean concentration of the drug remained within efficacious levels. So it was with the 300 milligram dose that they found that the mean concentration of the drug was actually therapeutic. And there was suppression of the high molecular weight kininogen to a level which is consistent to robust plasma kallikrein inhibition. So the donidrolesin, which is an antisense, I don't know if I pronounced it well, but it's an antisense oligonucleotide which targets and degrades the hepatic prekallikrein mRNA. So it's like inducing an antisense into the mRNA molecule and prevent the translation into a protein. So the idea is to prevent the plasma kininogen and subsequent kallikrein and bradykinin production. So the randomized phase 2 study in those patients who received donidrolesin reported a 90% reduction in mean number of HAE attacks per month, with 85% of the patients treated when they went to the open label had clinically improvement in the angioedema quality of life with 6 points or more. There were no serious adverse events which was related to discontinuation, and only 2 patients who reported injection site reaction. Finally, gene therapy, which I will not go through it, but this is something in the future. So this is a trial that is happening now, and I think it will end in 2028. So it is an investigation, single administration gene therapy, which intends to modify the disease course of HAE. It is a adeno-associated virus-based gene therapy vector. It expresses the wild type of human C1 esterase inhibitor, and hopefully we'll hear more results of this in the future. So in conclusion, there are a number of targeted therapies that have been developed and licensed for the management of C1 inhibitor HAE, and further novel therapies are under development, and these will include, and hopefully these will include HAE with normal C1 inhibitor function. Thank you.